Hi, Vikram. Hello.
Hi.
Hi, hi.
You are able to hear me, sir?
Absolutely. No problem. Yeah. Is there an echo?
Yeah, sir.
I don't know why. I think maybe somebody else also has logged on there on their own. Maybe that's the reason.
Participants on mute. If they are using the same Wi-Fi, this is the problem.
രാവിലെ തുമ്മല്ല ചെയ്യാൻ അത് രണ്ട് പ്രാവശ്യം സാധാ തുമ്മ
I think there is still echo, Vikram. You can hear me? I can't hear you. I can't hear you. There is still echo, a lot of echo when you talk.
Now it's. I can hear you. Can you hear me, sir?
I can hear you, but there is a lot of echo. I don't know if anybody else has logged on in the group, then probably it is echoing from there, I guess.
But you don't have any echo from your side. We can hear you absolutely well.
Oh, okay. When I talk, there is no echo?
No.
Oh,
we
okay.
can hear you pretty well.
Oh, okay. Okay, fine.
So, our classroom is full and I am the president, and as I promised you. But I guess
Your
my voice.
your audio is not, it's still echoing. I don't know why, but it is okay. I mean, as long as you can hear me, it's fine. But
Yeah, we are able to hear you very well. Is it still?
I think all people in the room, they have to, I think, disconnect from the Zoom, I think, because otherwise it will probably echo. I can hear you, but there is too much of echo.
Camera. So, is it still echoing? Slightly better.
Little better, for sure.
So, our classroom is ready. Few people have logged in from outside, quite a few.
Okay.
I hope the echoes have come down.
Yeah, better, definitely. Little bit is there, but yeah, better. I can hear.
Yeah, it's much better, sir. And your voice is quite good. No, absolutely, we don't have any problem. When you speak, I don't know whether it echoes to your ears, whatever you speak.
You can hear me?
Absolutely.
Okay. Yeah, this is fine. I think Yeah, I think it is just having different microphones on in the group sometimes may makes that.
Yeah, but now I think things are set.
Yes, yes, yeah.
First time
Yeah,
we are
sure.
launching it. So excellent, sir. So very nice to see you. Bada Kushi.
Good.
Everyone is actually they don't know that you are from my place, Bhadravati.
Ah, yes.
We
So
have,
you're at Sergi. This is a Sergi hospital.
correct,
Oh,
Sergi
okay.
Hospital.
Okay.
So we have a group of DNB students. We have a senior
Okay.
consultant, Dr. Vinay Patil, sir. Sir, I met you in the
Hi,
conference.
hi. Yeah.
So you had been here for one of the workshops, right? During the Criticon.
Yes. When Satish was around, yes, yeah.
Correct. And we also have our Dr. Viresh, IFB Shimoga chapter president. Viresh.
Yeah, hi, Dr. Viresh, hi.
So it's really good that we have you. And
Sure.
I'm definitely sure that we have a good learning experience. And Dr. Dhananjay Sarji and Dr. Prashant, who is the MS, medical superintendent, they wanted to convey their thanks through me and also through Dr. Vinay, and hope
Sure.
that you help us in our academic activities as and when you can engage with us. We have more to learn.
It is absolutely a pleasure. And I like small groups, PG's group. Catch them young. As they grow older, you can't teach them, you know.
Absolutely.
So it is better to teach them when they're right.
Correct. So all of them are young. You have caught them young.
Yeah.
And my other students from the medical college have also logged in.
Okay. Sure.
So it is going to be right now only pediatrics. Most of all the post-secondary students are pediatric department. However, along with Dr. Vinay and others, we've also disseminated to other departments also.
Sure.
If they are willing, they can always join. But probably because we have this period dedicated for academics in our pediatric department, it's easy for all of us to come. Maybe other departments, when they also start their academic program seriously, they may be able to come. So thank you so much. I'll hand over this to you. Please take over. Thank you.
So before I start, I mean, I just want to know, they're all first year, second year, third year DNB students?
All. First, second, third, all.
Second and third year. And they're already, I mean, I'm sure, you know, Sergi Hospital is very busy. So you have, they must have taken care of patients on the ventilator already. Most of them.
Yes.
Yeah.
Yes.
Okay. Now, see, you have given me 2 hours, Vikram. So I'll be very slow. And I am assuming that we are starting from the.
So our medical superintendent has come, so he switched on. I'll just introduce him to you.
Hi.
Hello, sir. He's Dr. Prashant, sir. After Satish, he
Hi,
has
Dr.
taken
Prashant.
over.
Hi, Dr. Prashant. Hi. Yeah.
It's a really nice gestures from you, sir.
No problem. I love teaching, and Vikram, whenever he calls, I'll come. No problem.
We were really happy that, you know, somebody of your stature is taking so keen interest and, you know, interested in teaching the youngsters. We are really always.
Thank you very much.
Platform is for you, you know. I think we'll continue the same, you know, work in the near future.
Yes, definitely. Yeah.
Whatever your area of interest and expertise, you can just share with us, and we'll make sure we'll have frequent meetings.
Sure, Dr. Prashant. Yeah. So, thank you, Vikram. Thank you for this opportunity. I always love, you know, interacting with the students. Definitely, that's what I'm missing here in Dubai. But yeah, so hopefully get to teach them and teach them the right thing. Now, I'm going to assume that, you know, we will start with very basics, because some some of these very basic things may look very trivial for those who are already doing ICU and ventilation, but I think learning the basics and reviewing it will actually strengthen the whole knowledge. So I'm going to start with very, very basic thing, assuming that somebody in the audience has never seen a ventilator or never done a ventilation, right? Let me just share my. Host has disabled participant screen sharing, it says. He needs to allow me to.
You can do it.
Yeah. Is the screen on?
Yes, yes, sir.
Is it full screen is coming?
Yeah.
You can see the full screen?
Yes, 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 yes.
Okay. Since there is 2 hours and we are only going to talk about the basics of mechanical ventilation, I would rather put it as probably interactive. I may ask few questions to your PGs, so they can answer or they can raise questions. So you can interrupt anytime so that we go stepwise and we don't miss the initial part. Right? You can see and hear me clearly, right? Hello?
Very, very well. Yes.
I can see. Okay. Okay. Let me just 1 second. Okay. So today I'm going to talk about basics of mechanical ventilation and modes of mechanical ventilation. Some of the higher stuff like advanced ventilation and all, we'll keep it maybe for the second talk as a follow-up to this. Now, anybody who has seen the ventilator or has taken care of a patient with ventilator, you are sometimes bombarded with all these terminologies. These are the basic terminologies. It is there in all the ventilators, rate, I time, tidal volume. You talk about decelerating flow, constant flow, PIP, P, plateau pressure, all those. So it can be quite daunting to look at all this and say, what does it actually suggest and what does it mean? And also nowadays, we also talk about mechanical power of the ventilator, lung stress, lung strain. I have put it in red because I'm not going to cover these in this talk because that is some sort of advanced ventilation talk, which probably we can do it as a follow-up. And also when you're looking at the ventilator, you see all these things, cycling, flow cycling, time cycling, pressure control ventilation, volume control ventilation, pressure support, SIMV. So these are all terminologies. Sometimes it looks like Greek and Latin, but hopefully at the end of this 1.5 to 2 hours talk, we will make sense out of all these terminologies. Now, let us start with the very basic. I mean, even if you are not, done ventilation, you have to understand that all the ventilator does is nothing but giving a mixture of air and oxygen into the patient. That's all it does. Now, that's all it was doing 40 years ago or 50 years ago. And even the modern ventilators of 2023 still do the same thing. But what has changed is we are making the ventilators more and more sophisticated so that it understands the patient's needs and gives what patient needs. But ultimately, what happens in ventilator is your air and oxygen goes in and air and carbon dioxide comes out. That's all it does. If you haven't done the ventilation before, understand that ventilator needs 3 inputs. One is the electricity to run the computers which are associated with the ventilator. You need air and oxygen mixture. So if you look at the back of the ventilator, these 3 things are there. You have the power button, and you have the air inlet and the oxygen inlet. Right? This is the oxygen and the air inlet. And of course, the power is needed because most of the modern ventilators need power to operate the complex computer system. So once this box, which you can see my mouse, right?
Yes, yes.
Yeah. So once the air and oxygen is put into the machine, depending on what you have told the machine, to do, it gives that output, which is like, see, this is to the patient. So this comes out of the ventilator and then goes through the humidifier, because we all know, you have to humidify the air which goes into the patient's lungs. Otherwise, normally our upper airways, nose, pharynx, and upper trachea humidifies the air. But if you are bypassing all those by ventilation, by endotracheal tube, if you don't humidify the air, by the time it reaches the trachea, there will be tracheal necrosis, sloughing. So you have to humidify the air and oxygen mixture which goes into the patient. And once it comes out, this is where you connect the patient to the ventilator, to the ET tube. So that is a basics, anatomy of a ventilator. So you have air going into the ventilator, oxygen going into the ventilator, and the machine depending on what you have set, it gives out particular type of breath, particular type of volume, particular type of pressure into the patient. And then the expired air comes back to the ventilator. So this is the basic anatomy of the ventilator. Now, if you go back and recall your physics, ultimately it is the flow, because see, we all talk about pressure ventilation, volume ventilation, which is better, which is worse, which age you should do pressure ventilation, which age you should do volume ventilation. All those arguments are nothing, because ultimately it is the flow which generates pressure and volume. Any gas pressure or volume is generated primarily by the flow. So when we talk about the ventilator, it is the flow which is the primary. That means air and oxygen is combined in the ventilator, and certain type of flow is created, which in turn determines how much pressure is generated or how much volume is generated. So when you talk about a particular type of breath given to the patient, you're talking about what type of flow it is. So there are various types of flow. This is a square wave flow. Square wave in the sense, see, this is your x-axis is time and y-axis is flow. So the flow goes up and then it remains constant and it goes down. So this is what the volume ventilation does, because volume can be measured if the flow is constant. So flow multiplied by time, you know that it is volume. So in a volume ventilation, always the flow is constant flow, so that then you can easily calculate the volume given to the patient. So the square wave is always the volume ventilation. There is another flow which is called decelerating flow, where the flow is reached quickly to a peak and then slowly it comes down. Suppose you want to generate a pressure as a primary variable, suppose pressure ventilation, you generate the flow in such a way that certain pressure is reached and then slowly it comes down. So this is what we use in the pressure ventilation. So ultimately it is the flow which determines whether it is a volume ventilation or a pressure ventilation. So these are the two major types of flow which is used in the modern ventilators. Of course, you have something called accelerating flow, which is rarely used, and also sinusoidal flow, which is difficult to create. And this is what actually the God has given us. We all breathe in a sinusoidal wave pattern, but this cannot be created so easily in a machine. So typically we have a square wave flow, that is constant flow, and a decelerating flow. Constant flow is used for volume ventilation, and decelerating flow is used for the pressure ventilation. So don't worry about whether pressure or volume ventilation is better, but think of it as a flow which determines the pressure and volume. There is no pressure, there is no flow, no volume if there is no flow. And also you can stop anytime, Vikram, if there is any doubt, anybody, you can stop. We have 2 hours, so. Yeah?
Yeah.
Hello?
Nothing. You can carry on, sir.
Yeah.
Carry on.
Yeah. Anytime you can stop me and ask questions. No, not an issue. Okay. Yeah. Now, let us look at how we breathe normally. Normally, so this is x-axis is time and y-axis is flow. Normally, we all breathe in a sinusoidal form like this. And as we know, inspiration is active and expiration is always passive. In normal breathing, we don't use expiratory muscles. Lung expands, chest wall expands, and chest wall recoils, and that causes the expiration. So we don't really spend any active energy during expiration. It is the inspiration which is active, and expiration is always passive, unless, of course, you have an obstruction, like in asthma, where you are using accessory muscles for exhalation. Why is this important? This is important because in the next few slides, you will know different types of breath based on what happens during inspiration, and expiration is passive even on the ventilator. So we don't talk much about expiratory phase on the ventilator. We mainly talk about the inspiration phase. So this is how we normally breathe. Whereas on a machine, we breathe something like this. As I told you, the constant flow. And again, as you can see, exhalation is always passive, determined by the recoil of the lung and the chest. So it is only the inspiration which is supported by the ventilator. There is no ventilator made which actually helps in exhalation. Of course, to an extent, high frequency oscillator, because of the oscillations, you can say to an extent the exhalation is supported, but there is no ventilator made which can help in exhalation. All the ventilator does is help the inspiratory part. So this is the volume breath. As we see, I told you this is a constant flow. Why you need a constant flow for volume breath? Because in order to measure how much tidal volume is delivered, volume is equal to flow multiplied by time. So if I have a 2 liters, if I open the tap and the flow is at 2 liters per minute, if I hold a bucket under the tap for 1 minute, you will have 2 liters of water. Just like that, if I have 60 liters per minute flow and I have given 1 second as inspired volume, at the end of 1 second, you will have 600 cc of tidal volume. That's how the volume is measured on the ventilator. Volume is measured on the ventilator by flow multiplied by time. So that's why you need a constant flow for volume ventilation. Now, this is a pressure breath where the flow reaches the top and then gradually decreases once the peak pressure is reached. This is a deaccelerating type of flow which is used in the pressure breath. Again, exhalation is no different in any ventilator. It is the patient's lung and chest recoil which causes exhalation. So when we are talking about ventilation, you can actually forget about exhalation for a while because it is only the inspiration which is supported by the ventilator. Now, so different phases of a breath. So what happens during different phases of a breath on a ventilator? So now this is inspiration, as I showed you, and this is exhalation. So certain basic terminologies I would like to explain. From inspiration and the expiration, that is beginning of one inspiration to the beginning of next inspiration, this is the whole thing is called the total cycle time. For example, if I am breathing at 20 per minute, that is 20 per 60 seconds, my total cycle time will be 3 seconds because every 3 seconds I'm taking a breath. And in that, this is time spent in inspiration, this is inspiratory time, and this is expiratory time. So basically your total cycle time is inspiratory time plus expiratory time. So if I am breathing at say, so if I am breathing say at 20 per minute, my cycle time is 3 seconds. If I give inspiratory time of 1 second and exhalation time of 2 seconds, that means it will be 1:2 IE ratio. Okay. Now, how does the machine give a breath, right? So what happens is, when the machine is ready to give a breath, we always think that inspiratory valve opens. No, it is not that. Actually, when the machine gives a breath, it is the expiratory valve which closes, so that the force is generated in the ventilatory circuit and the inspiration happens. So beginning of inspiration here, the exhalation valve closes, right? So always think that the exhalation valve is the primary. There are no inspiratory valves. There are expiratory valves only, right? And once the exhalation valve closes, depending on whether you volume, here we are talking about volume ventilation, so I'll stick to that. But whether volume or pressure, you set certain volume and pressure, and machine gives certain flow to reach that tidal volume, depending on what inspiratory time you have given. As I told you, volume is flow multiplied by time. Or if it is a pressure ventilation, the flow is created in such a way that certain pressure is reached. So this is where the peak inspiratory flow rate happens, determined by what you have set, whether tidal volume or pressure. And then once that is reached and end of inspiratory time, exhalation valve opens so that the patient is allowed to breathe out. So the patient is breathing out passively. That means exhalation valve opens and you can breathe out. So as I reiterate, expiration is passive even on the ventilator. So we are only worried about these three phases. That is beginning of inspiration when the exhalation valve closes, peak inspiratory flow rate happens to determined by what pressure or volume you have set, and beginning of expiration when the exhalation valve opens. So remember these three, because this is a paramount importance when you're talking about modes of ventilation and other things, right? Okay, now even if you look at the ventilator's comfort, there are certain basic parameters you have to set. Of course, the modern ventilators have hundreds of parameters you can set, which makes it more confusing. But basically, minimum you set is a respiratory rate. Let us say 20. That means 20 per minute. That means each cycle time is about 3 seconds. So total cycle time is 60. So if you have set a rate of 20, it is 3 seconds for each breath. Now, out of that, let us say I set a time of 1 second. So that leaves with 2 seconds for the expiratory time. So that means IE ratio is 1:2, which is considered as physiologic. That's what we breathe. We take 1 second to breathe in and 2 seconds to breathe out. So that's what generally we tend to put on the patient, unless, of course, if you have an obstructive lung disease where you want to give a prolonged expiration, then you make it 1:3. Or if you have a very difficult patient to ventilate, you may give more I time in order to reach, reach higher mean airway pressure and better oxygenation. So this is just for an example. I'm telling that this is the minimum ventilation. I mean, when I was doing post-graduation 30 years ago, basically we had bird ventilator, which had only these settings, nothing else. And of course, the peak pressure. No other parameters had to be set. So life was very simple, right? But of course, we had to put a lot of chest tubes. We had to, so those sort of things were because the patient ventilator synchrony was not there. So these were simple settings we had to set. And another thing you might have seen on the ventilators is inspiratory rise time. Most of the time, we don't change this parameter, but it is important to know what it is, because by mistake, if we change it, it has some consequence for the patient. So what is inspiratory rise time is, basically this is on the pressure mode. It doesn't make so much difference for the volume mode, because as I told you, in the pressure mode of ventilation, the flow is decelerating flow. You reach the peak flow and then slowly come down. Now, what is inspiratory rise time is how fast you want the pressure to go up and reach the top. It can be like this, it can be like this slope, or it can be like this slope that is too fast, very fast, or it can be much faster, right? So it can be like this, pressure can reach like this, pressure can reach like this, or pressure can reach like this. How does it make a difference? Because Suppose if it is too fast like this, then what happens is it is like blowing air, putting a blow of air into somebody's face, which can be very uncomfortable, right? So if it is too fast like this, it can be very uncomfortable for the patient. But if it is very, very slow this way or much slower, then patient may not get enough air when he needs it, right? So he will have air hunger. So normally we don't change it. Usually it is about 5 to 10% of the cycle time. So for example, if I have a cycle time of 3 seconds, 0.3 or 0.15 will be the inspiratory rise time. That is ideal. We generally don't touch it unless under special circumstances where you are treating a patient who is very hypoxemic and he needs more flow or faster flow. In those circumstances, we change it, but otherwise, generally, we don't change this parameter on the ventilator. It's usually about 5 to 10% of the cycle time. Very short time, I told you, times is uncomfortable for the patient. That means it is very, very fast. It is like blowing air into the face of the patient. Or very long rise time may result in lower tidal volume and the patient may have air hunger. So ideally, it should be around 5 to 10% of the cycle.
Sir, one thing.
And important, sorry, yeah. Yeah, tell me, Vikram.
Previous slide, sir, previous slide.
Yeah.
So you meant to say inspiratory rise time will be kept the same, or it comes with the factory setting that it is maintained at 5 to 10% of cycle time, sir?
Yeah. So this is inspiratory rise time. Do not mistake it for inspiratory time. Right?
Yeah,
I time is different. I time and E time we talked about in the previous slide, right? Here we talked about I time.
Inspiratory
right?
rise time, sir. Inspiratory rise time.
Yes, correct. So this is inspiratory time, which is 1 second and 2 seconds. If I say that 10% of the cycle time will be inspiratory rise time, that means in this particular example, for example, 3 seconds, I put 10% as an inspiratory rise time. Whatever pressure I set will be reached in 0.3 seconds. And rest of the time, it will be staying there. I think I made myself clear, or?
Yes.
Yeah. So this is inspiratory time, whereas this is inspiratory rise time. That means how fast it reaches to the level, and then it stays there like this. So this whole thing will be 1 second. 1 second. 1 second.
Yeah, sure. ಅಂದ್ರೆ ಅಲೋ ಆಲ್ ಅಂತ ಮಾಡ್ಬೇಕಲ್ಲ ಅದು ಹೆಂಗದು
waiting room disable
everyone. So the inspirator rise time is set by the company.
Hello, sorry, yeah. Sorry, Vikram. Yeah, that's from the hospital. Yeah, tell me.
No, the inspirator rise time is usually whatever is set by the company will remain, no, sir?
But you can change it. You can change it if you want to. You can change it, but do not change it. Unless it is needed. It is rarely changed. I mean, 5 to 10% is the default.
Okay.
Yeah, but by mistake, somebody goes into the system and changes it to, like, say, let us say 20 or 30% by mistake, and then the patient may be won't get enough pressure.
Okay.
So that's why it should not be changed unnecessarily. Yeah.
Okay.
And usually it is not. It is a hidden. Since you don't see it, you have to go in there and change it. Sometimes what happens to people who are doing it for the first time, they make mistake this for an inspiratory time. This is not inspiratory time. This is inspiratory rise time.
Right, sir.
Yeah. For example, if you put inspiratory rise time as 1 second, that will be quite disastrous for the patient because you won't get enough flow, right?
Okay.
Generally, there are. I mean, usually the companies do not allow it more than 30%. By default, it doesn't go up more than that.
Okay.
as a safety.
Right. Because this was something new. I had never heard of this.
No, absolutely. I think, see, every slide you can interrupt me because one slide is, I mean, the next slide will be much easier if you understand the concept very well.
Right.
Yeah. Anything else?
Sir,
no.
Yeah, Dr. Vinay had to ask.
Sir, if
Yeah,
you
tell me,
come-
Vinay.
Sir, if you come very close to the system, your voice is inaudible. So
Oh,
please
okay,
be-
okay.
Yeah, okay.
Better now?
Yes.
Yes.
Oh, okay, okay. Yeah. Now, so this is the inspiratory rise time. So we go through this. So now the other concept, important concept, is the PEEP, because every ventilator, modern or otherwise, older ventilators had something called positive end expiratory pressure. So this is very, very, very important concept. If you ask me, a single most important concept in a ventilator is the PEEP. So it is good to understand this, and I'm sure all of you have blown balloon, right? At some point in your life. So how does it look when you start blowing a balloon? 1 second. Okay, so this is where we start, right? This is a flaccid balloon. We pick up a balloon. There is no pressure. There is no volume in the balloon. Balloon is completely flaccid. I'm just comparing the lungs to the balloon, which is probably a simplistic way of looking at it, but it gives you a good understanding of how the lung works. So balloon is flaccid. Pressure is 0. Volume is 0. There is no air in the balloon. You start blowing a balloon. You all know that initially it is very difficult to blow the balloon. First part, correct? So you start blowing a balloon. Basically, you are raising the pressure from here to here. A lot of pressure you are given, but you have only got this much volume, right? So that is because the balloon was flaccid. Balloon was flat. Balloon's compliance was very poor because it was collapsed. Now you change the pressure this much, but only this much volume is changed. That means the the balloon's compliance was very poor. As we know, compliance is change in volume divided by change in pressure. Here, very little volume is changed for a significant increase in pressure. But we all know after certain amount of pressure, volume is reached, certain critical volume is reached, it becomes very easy for the balloon to be blown further. We all know that, right? When we blow the balloon. That means the same balloon, now after this critical volume is reached, only this much pressure change, but there is an enormous increase in the volume of the balloon. Why did that happen? Because after this critical volume is reached, it was easy to blow the balloon because the compliance improved, right? The same balloon, there is nothing, just one of the reason is also because the volume, the wall of the balloon becomes thinner, right? So why is this concept very important in lungs? We'll come to that. But we also know that once this volume is reached, once certain volume is reached, you keep blowing the balloon, it becomes difficult again, right? So this is again, it becomes like this. It becomes one like this. It is very difficult to blow the balloon here, and it's very difficult to blow the balloon here, but it is very easy to blow the balloon from here to here. Why is this? What is this in relation to the lungs? In relation to the lungs, when we give positive end expiratory pressure from 0 to certain PEEP here, then what happens? The lung compliance improves and it becomes easier to blow the balloon. So this volume is, any answer from the audience? What is this volume called? Where the compliance is the best?
So residual volume is what everyone is asking.
What is that? It is functional residual capacity, FRC. This is the FRC. That is where our compliance is the best. That is why when we give PEEP, what you are trying to do is bring the lung to FRC so that it becomes easier for you to ventilate the patient or for the patient to breathe on his own. That's what the CPAP does. Basically in CPAP, you're trying to bring the lung from here to here so that the patient can be breathing comfortably around that. So the function of the PEEP is to bring the volume to the FRC. right? That is the concept of FRC, and that is the concept of PEEP. So this is basically your classic pressure volume loop. You want to be ventilating somebody around here, not here. If you have a PEEP of 0, that means the patient has to do so much of work to move the same tidal volume. Whereas if you give a PEEP and then make him breathe, he has to work a lot less, or ventilator needs a lot less pressure to ventilate, right? So that is the concept of compliance. Compliance is change in volume divided by change in pressure. Stiff lung means less compliance. Well-compliant lung means it's a healthy lung. So what are the advantages of PEEP? So it makes the lung more compliant, and hence less of work of breathing. And by keeping the lung open, it makes oxygenation better. And also we will not talk about cardiopulmonary interaction, but because that's another different talk altogether. It does decrease the workload on the heart. It is a complex mechanism, but that's an interesting talk by itself. We'll not go into the details of that, but it decreases the workload on the heart. That's why a child with cardiomyopathy, when they are in congestive heart failure, you put them on a ventilator, it works like an inotrope. In the sense, it actually helps them, particularly the left ventricular failure. If somebody comes with a cardiomyopathy with left ventricular failure, you put them on ventilator, their circulation gets better. That is because it is less workload on the heart and it decreases the afterload. Now, FRC is also a sweet spot for various other things. For example, this is a graph which shows this is the graph basically which shows volume on the x-axis, and y-axis has either compliance in blue, resistance in red, and pulmonary vascular resistance in compliance of the heart, lungs in blue, resistance of the lungs in the red, and pulmonary vascular resistance in the green. And you can see FRC is the spot where you have the least pulmonary vascular resistance, best compliance, and least airway resistance. So ideally, you should be ventilating anybody around the FRC, right? That is why PEEP is very important, because it decreases. Because always this, how is it clinically important? Because sometimes, somebody is in shock and also has ARDS. Some of my PGs used to say, sir, I don't want to give PEEP. Why? Because PEEP decreases the venous return and cardiac output. Yes, it is true, but a collapsed lung, if you have a collapsed lung, it also has increased pulmonary vascular resistance. So an optimally inflated lung has the least pulmonary vascular resistance. So unless pulmonary vascular resistance is low, nothing goes into the lungs, and left ventricle gets only what goes to the lungs. So circulation will be better when there is an optimal pulmonary vascular resistance. That is low pulmonary vascular resistance. So in a collapsed lung, because pulmonary vascular resistance will be high, it affects the cardiac output. Once you open up the lung with PEEP, and if you overdo it, yes, it does decrease the cardiac output. So that is why you should be ventilating anybody around the functional residual capacity. As you collapse the lung this way, that means you are going towards the residual volume. Your compliance is poorer, your resistance is higher, and your pulmonary vascular resistance also goes up. As you hyperinflate the lung towards total lung capacity, again, same thing happens. Your compliance goes poorer, and airway resistance increases, and pulmonary vascular resistance increases. Got this? Can go next.
Yes, beautifully demonstrated, sir. Very nice graph.
Yeah, this is one of the best graphs in pediatric intensive care for me. This is one of the best graphs for pediatric intensive care. It says so many things actually. Yeah.
Absolutely.
Yeah. Okay. So ideally, FRC is the best for all of these things. Now, the other concept is airway pressures and alveolar pressures. See, when you see these modern ventilators, when you say peak inspiratory pressure, which comes on the machine, where do they measure it actually? See, ideally, you should be measuring all these at the tip of the endotracheal tube. But unless for research purposes, we don't do it. We don't put a catheter into the trachea, endotracheal tube, the tip, and measure the pressure. Most of the ventilators actually measure these pressures inside the machine, right? Some of the ventilators measure the pressure at the proximal end of the endotracheal tube, where your Y connector connects to the endotracheal tube. But Maquet ventilator measures the pressures inside the machine. So that is the airway pressure we measure here, right? Here we measure it here at the proximal end of the endotracheal tube or at the machine. But what we are actually interested is how much pressure is seen by the alveoli. That is what is important, right? Because for all purposes of, say, for example, when we are talking about barotrauma or volute trauma, we want to know how much pressure is actually seen by the alveoli, right? But that is not normally measured by the machine. What we measure is the peak pressure at the proximal end of the endotracheal tube or in the machine, proximal end of the circuit. And alveolar pressure is not measured routinely by the machine. Why is it important to measure both? Important to know both is because the pressure difference is due to the airway resistance. See, this is a simplistic model of the lung. We think that this is all airway and this is all alveoli. That is not. It's a two compartment model. It is not like this. There are millions of small airways and there are trillions of alveoli. But for understanding, you can say this is airway compartment and this is alveolar compartment. Suppose you measure a peak pressure of 30 and you measure the alveolar pressure is, say, the peak pressure is 30 and alveolar pressure is 10. That means that 20 of those pressure is lost due to the airway resistance. For the air to move from here to here, that much pressure is lost. For example, if peak pressure is, say, 50 and the alveolar pressure is only 5, that means 45. That is typical of a obstructive lung disease. For example, an asthmatic. When you are ventilating an asthmatic, if his peak pressure is 50, but his alveolar pressure is only 5, his 45 of this pressure is lost because of the airway resistance. Why is it important to know both? For example, if I am ventilating a patient with obstructive lung disease like asthma, even if I hit a pressure of 45 or 50, I would not be so worried because I know that only part of this pressure is actually seen by the alveolar pressure. Rest of it is all to overcome the resistance of the airway. Whereas if I see a peak pressure of 50, when I am ventilating a patient with ARDS, I know I am in big trouble, right? Because that is, if I know that there is no airway disease, it is purely a lung, parenchymal disease, then alveolar pressure being 45 and peak pressure is 50, that means I know that this is a very significant lung disease and it can cause a lot of problems. So you have to look at peak pressure and alveolar pressure in the context of the patient. For example, if I'm ventilating a patient with obstructive lung disease, if 45 or 48 of peak pressure doesn't bother me much because I know once I bronchodilate with whatever options are available to me, bronchodilators, magnesium, whatever, then I know that that pressure will come down quickly. Whereas if I'm ventilating a patient with ARDS and I'm requiring 45 or 50 of pressure, then I know that this is quite serious and I should start thinking of further high frequency or ECMO or whatever, right? So this is very important. Now, peak pressure is, as I told you, it gives on the machine, whereas alveolar plateau pressure. How do we measure alveolar or plateau pressure? PGs?
How do you measure plateau pressure?
Yeah.
How do we measure the plateau pressure? Sumit?
During inspiration, hold.
Yeah.
Inspiratory.
You're right. Inspiratory hold. That means these are there. Modern ventilators, there is buttons to do that. Just hold the button, inspiratory pause. Then what happens when you are doing the inspiratory pause? What is happening is basically you equalize the pressure from here to here. So there is no flow. There is a no flow situation for about, say, 1 second or 2 seconds. And then the pressure equalizes from here to here. And whatever number you get at that time is the plateau pressure or alveolar pressure, right? So this is something which you should always do when you are ventilating a patient with significant pressure, so that you know the alveolar plateau pressure. Now, for that, you have to make sure that the patient is not struggling. For example, if you do an inspiratory hold and the patient is trying to cough, that will not give you the correct number. So when you do the inspiratory hold maneuver, you should make sure that the patient is well sedated or paralyzed before doing it. That is when you get the correct number. And of course, modern ventilators can also continuously give the plateau pressure, and they will measure it continuously, even without the hold. It is sort of computerized,
Dynamic.
analysis. Yeah, so dynamic it will give you, but ideally you should do the maneuver and check. Why that is very important, particularly in a patient, whether you want to know whether it's significant obstruction is there or significant restrictive lung disease, because the difference between peak pressure and alveolar pressure will give you that idea. So what is, these are the other concepts, delta P and driving pressure. I don't want to bore you with all this now because this is a little higher end, but since we are here, I just want to mention delta pressure is PIP minus PEEP. That means, for example, if you are ventilating somebody with a 20 of PIP and 5 of PEEP, delta pressure will be 15. Whereas driving pressure is plateau pressure minus P. That is the difference between delta pressure and driving pressure. This is for little advanced class. We will talk about what is the significance, what should we be targeting, and all those things maybe in the next talk. And this is also another advanced thing nowadays we get to hear. This is mechanical power. Ultimately, we say that, okay, we are causing ventilator-induced lung injury is not because of the pressure, not just because of the volume, not because of the rate. There's a complex amalgamation of rate, pressure, volume. So if you put all those together, volume, pressure, rate, so how much are you beating up the lungs? So that is mechanical power. Again, this is a advanced concept. We will not go into the details in this class, maybe later. Now, we also know that, sorry, Vikram.
You're having a cup of coffee without your permission.
Oh, I'm also having my coffee. I'm ready.
Cheers.
So, go ahead. Yeah. I knew you had given me 2 hours of talk, so I thought I should be prepared with coffee.
Yeah. So it's getting only
Unfortunately, you can't send it over email. Otherwise, I would ask you to send a cup.
So it is getting more and more interesting, sir.
Yeah. Okay, I can pause for a while if you want to, No problem.
No. In fact, we don't want you to stop. Unless you want to have a cup of coffee.
No. I can keep having coffee and talking, no problem. So another concept, see now, when you have somebody, patient on the ventilator, now we are talking about peak inspiratory pressure, we talked about PEEP, we talked about plateau pressure, what the alveolar are seeing. But what we are forgetting is there is also a pleural space of the lungs, and there is also atmosphere outside.
Sir,
right?
1 second.
Yes?
When you assume this position, we are not able to hear you well.
When you come closer to the system,
we can't hear you.
Oh, okay. Now this is better?
Yes.
Oh, okay.
Yes.
Sorry. I don't know why, because I'm on the AirPods. So naturally that speaker, laptop speaker should be off, but okay, fine. Now it's better?
Yes, absolutely.
Okay, I'll stay like this, yeah. So now look at this one now. So we talked about the intrapulmonary pressure, that is your PIP, PEEP, plateau pressure. But we also, around that, you have a pleural space, right? And of course, outside the atmosphere, that is, yeah. Now, why is this important? Because now, how do we measure intrapleural pressure? Pijis? How do we measure intrapleural pressure?
Anybody? I have no clue.
Answer is in the slide, actually. Yeah. So, I mean, ideally you should put a catheter in the pleural space and do it. That is only done for research purposes. But the surrogate is actually the esophageal pressure, because it is right next to the pleural space, the lower end of the esophagus. All right. So you can easily measure depending on the, I mean, you can put a balloon into the lower end of the esophagus, and that is how we clinically measure the esophageal pressure, which will give you an intrapleural pressure estimation, right? Now, why is it important? Now, let us just think, because I mean, if I'm doing the workshop, I actually bring all these things and I can show you. But let us assume that you put a balloon, you start blowing a balloon. Let us say you blow the balloon to 50 centimeter of water, right? The same balloon, I will ask you to put it in a dense glass container or dense steel container and blow it to 50 centimeter of water. Which of the balloons is likely to break?
The one in the
One with the
yeah.
open one. The one with the
One is
open
which
one.
is the open one.
Open
Why
one.
is that? Why is that?
Because nothing supporting that.
Right. So whose transpulmonary pressure will be high? The one inside the balloon, one inside the glass or steel, because the wall is rigid, it will exert pressure inwards. So the transpulmonary pressure will be low, right? The one which is not supported has very high transpulmonary pressure, correct?
No, can you just come back, come again, sir?
Okay. Yeah. So now let us say, this is what you can see my this thing, right?
Yes,
Yeah.
sir, yes.
Okay. Follow this, cursor. So let us say this is a glass or a steel rigid container. I have put a balloon in this, right? And I will blow. It will expand. It will come here, and beyond that, this wall will not see the pressure, because all of those pressure are taken up by the rigid wall, right?
Yeah.
Whereas if I take away this rigid wall and just keep blowing this balloon, at some point it will break the balloon. Yeah.
Yes.
So what is the clinical context? I'm coming to the clinical context. For example, we used to say that we should always allow patients to breathe on their own, right? As much as possible, which is true, which is even today it is true. But I'll go to this slide, next slide, and tell you. For example, I have a severe, let us say I have a child with severe ARDS, right? One child I have put on muscle paralysis in the first 1 or 2 days, and the other child I have put on spontaneous breathing. Now, which lung is at risk for a stretching and stretch injury and stress and strain?
Everyone in unison says spontaneous breathing.
Correct. Because see why? Suppose I'm giving them the same 20 centimeter of water of airway pressure, right? In the muscle paralyzed patient, chest wall is imposed on the lung, because there is no chest wall is not moving on its own, so it is just collapsed. So this is like a rigid container, and this is like a balloon in a rigid container. So 20 centimeter of water is, it won't go beyond that. Whereas here, if the patient is breathing, he is trying to pull the chest wall outward, and you are giving 20 centimeter of water. So basically, this is adding to the transpulmonary pressure. Whereas this one here, in fact, the transpulmonary pressure is less because the chest wall is tending to be collapsed on the lung. Whereas here, the wall is going away from the lungs, so this lung will expand more and more. So this is a very important concept, because this is, see here, transpulmonary pressure is 25, whereas here it will be 15, because 5 centimeter of water is acting this way, whereas here 5 centimeter is acting outwards. Why is this important in lungs? Nowadays we have realized what is called as a spontaneously breathing induced lung injury, PCLI, right? So if you have a severe ARDS, it is always better, because we have gone through a cycle, like, We usually used to paralyze the patients all the time for a few days. And then we said, paralysis is not good. We have to let the patient breathe on their own. And now we have come back to a situation where if it is severely affected lung with ARDS, and if the patient is breathing, if patient's drive for breathing is too much and is breathing too fast and too much, it is better to have them paralyzed for a couple of days because of this concept. I got the concept right?
So brilliant, sir. We never knew this.
Okay, so this is the same. This is the same. So importance of transpulmonary pressure. So don't know, not every patient will need a esophageal balloon, but it is important to measure the transpulmonary pressure if possible. Another clinical context for this, I will tell you. For example, we all see dengue patient, correct? With ARDS.
Right now, there is one admitted.
Let us say he has moderate massive pleural effusion, which normally we don't drain. I mean, with the risk of bleeding and all those things. Now, if this patient, if I am giving a tidal volume of 6 cc per kilo, and he is generating a pressure, say 40 or 45, I would not be so much worried. Because why? Because his intrapleural pressure is very high, right? So whatever pressure I am using, part of it is actually going into expanding the lung also, but at the same time to overcome the pressure generated by the pleural fluid. So his risk of injury to the lungs per se is much less because not all the pressure we are giving is actually transmitted to the alveoli. Part of it is actually taken by the pleural fluid. Correct?
Yes.
So that is where the concept of your transpulmonary pressure. So transpulmonary pressure is not only, it is a combination of what you want, what you need to expand the lungs, and also what you need to expand the lung, I mean the chest as a whole. Yeah, chest as a whole. Okay, transpulmonary is from the airway to the atmosphere through the lungs. I hope I made this concept clear.
Yes.
Yeah. Okay. So we'll move on. So this is the concept. And always, whenever these things come up, we always want to know whether there is any study which shows that this is true. And this is a beautiful, actually study. It's one of the hallmark study actually. If you look at this. Yeah. So you can see here. This is the group of patient where your PEEP is constant. Your PEEP is constant. Let us say he was on a PEEP of 10, but his delta P, that means PIP minus P, kept on increasing for the same PEEP, and the mortality also increased. You can see this here. Now, this is a second patient, second group. Here, the PEEP increased, but the delta P remained constant. So then the mortality remained constant. Whereas here, PEEP kept on increasing and delta P is reducing. Then the mortality decreased. So what does it say? It says that what is most important is you have to minimize the repeat stretch and collapse of the lung. So the most important concept is keep the lung open with optimal PEEP, even if it is high, but minimize the difference between the PIP and PEEP. That means our plateau pressure minus PEEP, that is driving pressure. So minimize the driving pressure and optimum PEEP will give you the best possible scenario for lung injury. In the sense, it will avoid the lung injury. Got the point? I hope I made it.
Yes.
Yeah?
Absolutely.
Okay.
Yes.
Yeah. So now I hope all this now it makes sense, right? The first beginning of the talk, I gave you this slide, I just want to make sure all of these are now very clear. What is resistance, what is compliance, what is plateau pressure, constant flow, decelerating flow, and all those things, right? Yeah. So now we'll go to this. This is another thing we need to decode, right? What is this? Flow cycling, time cycling, SIMV, PS, APRV, BiPAP, IMV. And also please remember, before we go further, some of these modes may be exactly same, but a lot of these names are trademarked. For example, APRV, right? Airway pressure release ventilation. It is sort of a trademarked ventilation mode by a certain company. So nobody else can use it. But they use the same concept and use something called bi-level ventilation, bi-level airway pressure ventilation. So it is the same thing, but marketed in a different way. So best thing is to go into their, any ventilator you buy or new ventilator you're operating, go into their manual and see how exactly it works. So that may be exactly same mode as one other ventilator you might have already used, but called by a different name. That mode may be called different name, right? So that is very, very important because a lot of these modes, for example, volume support, somebody may call it as volume guarantee, but volume support and volume guarantee are essentially the same. Or mandatory minute ventilation may be the same as volume guarantee. So it is important to go to their manual and read and see that that's what they mean, right? Okay. So to understand this, now we have to go back to coming in my way. Yeah. How do I get this bar out of it? So 1 second. Okay, so now we'll go to the phases of inspiration, right? We're going back to the same thing. Sorry, there was a question, Vikram? No.
No, the time set for 2 hours was we wanted it to go slow so that everyone could follow. So
is it okay? Now speed is fine. Okay, good.
Yes,
good. Yeah. So we'll come back to this slide, which I had put it up initially. This is what the normal breathing looks like on a ventilator. This is constant flow ventilation, that is volume ventilation. And as I told you, when you are on a ventilator, forget about the expiration. You don't need to know anything because the expiration is passive, even on a ventilator. There is no ventilator which supports the expiration. So all we need to know is these 3, 1, 2, and 3. You can see my cursor, right? Clearly?
Yes.
Okay, 1, 2, and 3. So what are these 1, 2, and 3? So this is beginning of inspiration when the exhalation valve closes, right? Exhalation valve closes and the inspiration begins from the ventilator. Then certain amount of flow is reached in order to achieve certain volume in this case, or if it is a pressure ventilation, in order to reach certain pressure. And then exhalation valve opens and the beginning of inspiration happens. These are 3 important phases of inspiration, and every mode of ventilation depends on what happens during this. So if you understand these 3 phases, you will understand everything about ventilation. Yeah? So the first question is here, beginning of inspiration. First question is, who initiates the breath? See, suppose you are on a ventilator. Does patient initiate breath or the machine initiates the breath? That is the first question you have to ask. And then the second, what is the limit? Right? As we talked about, whether it is a pressure limit or a volume limit. And then the third is, who determines when to cycle? Like for example, okay, I had enough of I want exhalation. Does the machine determine or the patient? So if you understand these 3 questions and 3 concepts, every mode will be easy. All modes are based on these 3 important concepts. Right?
Sir.
Yeah.
You were again
yes,
not audible. You came close.
Oh,
and
sorry. Yeah, sorry. I'll restart. Yeah. So we'll go back here. Yeah. I sometimes sorry about that. Yeah. So basically, we'll talk about these three phases, right? Because forget about exhalation, because exhalation is passive. Now we will start with this beginning of inspiration. That is when exhalation valve closes. Then a gush of air comes into the patient. So this is one important phase. And the second one is peak flow is reached in order to achieve certain tidal volume or certain pressure. And then the exhalation valve opens so that the exhalation patient can exhale. So these are three important phases which determines what type of mode we are using and what type of breaths happen. I'm okay now, Vikram?
Yes.
Okay. Now, each phase, you have to ask a question. Who is initiating the breath? Is it the machine or is it the patient? Right? Only two possibilities. When you are on a ventilator, either the machine initiates the breath or patient initiates the breath. What is the limit? As I said, flow is the primary factor, but what we set is not usually the flow. What we set is the pressure and volume, right? So what is the limit? Volume is the limit or pressure is the limit? And then who determines when to cycle? Like in the sense, is the patient is determining this is the time to open up the exhalation valve and let me exhale, or is it the machine which determines let me exhale, let me open up the exhalation valve and let the patient breathe out, right? So these are three important questions. I mean, you have to always think any mode based on these three things. Now, so that is a 3-question strategy to understand the mode of ventilation. So the first question, who initiates the inspiration and how? Remember the first phase, exhalation valve closes and inspiration is started, right? Exhalation valve closes and the inspiration starts. Who initiates this and how? So what are the possibilities? I told you there are only two possibilities. Either it is the machine or the patient. Second question is, how far is the inspiration allowed or what is the limit for inspiration? That is otherwise called as limit variable. First one is called trigger variable. What triggers the breath? What is the limit for the breath? And the third is when and how is inspiration ended? And cycle variable, cycling from inspiration to expiration. So these are the three variables you need to understand the mode of ventilation, depending on the three phases of inspiration. Let us take one by one. Who initiates the breath, right? So when patient is on the ventilator, there are only two possibilities, right? Either it is the machine or the patient. Machine in the sense, clinician, basically. What we set on the machine will tell the machine when to initiate the breath, or patient himself can initiate the breath. So how does the machine know when to initiate the breath? PGs, anything?
Flow or pressure generated.
Can they explain that? What do they mean by that?
When there is a pressure change by minute pressure changes, if there is positive pressure, if there is negative pressure generated initially of
no, that is the machine, but the machine doesn't know that. That is patient. That is what patient is doing, right? When patient takes a breath, the pressure drops or the flow drops. That is when the machine triggers. But if you want the machine to take control, how does the machine know how to breathe? How can you tell the machine to breathe for the patient? What do you set on the machine which tells the machine to give a breath? Yeah, I can't hear. Yeah, I can't hear.
Set the time.
Exactly, set the time, right? The only way the machine knows, for example, you tell the machine, I want a rate of 20. So what are you telling the machine? When you say rate of 20, you are telling the machine every 3 seconds, give a breath, correct? Right?
Yes.
So that is called time triggering. So no matter what, every 3 seconds, machine will give a breath. right?
Yeah.
So that is called time triggering. What you are talking about, pressure and cycle triggering, we will come to that. That is, how does the patient will tell the machine, see here in the machine, this one, clinician is telling the machine to give a breath. That means I have set a rate of 20. That means I'm telling the machine, give a breath every 3 seconds. That's it. The machine will do that. Now, if I want patient to determine when to breathe, then how does the machine know? How does patient tell the machine how to breathe, when to breathe?
Negative.
Yes, that is what you were telling before. That is, either it is pressure triggering or flow triggering or neural trigger. We'll come to that, right? Okay. So what do you mean by pressure triggering?
Some negative pressure generated is what they're saying.
Correct. So when the patient let us say when the patient begins to take a breath, there is a negative pressure generated in the circuit. So then the machine senses that pressure drop and gives a breath. That is called patient triggered, pressure triggered breath from the patient. That is patient triggered, pressure triggered breath. That means, see, and imagine, you have to understand this happens in microseconds or even nanoseconds. That is how good the modern ventilators are. Suppose patient begins to breathe, first nano or microseconds, there is a drop in the pressure that is sensed by the machine, and machine thinks, okay, patient is breathing, let me help him with the breath. So it will give a pressure breath or a volume breath. So this is only possible in the modern ventilators because we have such a fast responsive computers, right? It was not possible 40 years ago because there were no such fast responsive computers. So basically when patient breathes in the first microseconds, because see, we breathe at 20 per minute. That means our cycle time is 3 seconds. Our inspiratory time is 1 second. If the machine takes 0.5 or 0.6 seconds to know that I'm beginning to breathe, there is no use if it gives me a breath at the very end of my effort, right? So, but the modern ventilators do it in microseconds. That means out of that 1 second of inspiratory time, first few microseconds, when I begin to breathe, machine senses it and gives me a breath. That is pressure. Am I clear?
Yes. And please, yes.
Yeah, sorry. When I get excited, I come in front and talk. So sorry. I will stay back. So now, flow triggering is similar to that, but instead of drop in the pressure, machine senses that the patient is taking a little bit of flow inside, and there is a drop in flow, and it senses that as a patient effort and gives a breath at that time. Does it make sense?
Yeah. Yes.
Okay, now these are all happening after the flow starts. Now, how good it will be if we can sense when the medulla oblongata of the patient starts thinking of giving there is a trigger from medulla oblongata, and that is sensed by the machine, and it is also sensed by the it is sensed by the machine and gives a breath, rather than that signal going to the diaphragm contracting, causing negative pressure in the pleura, and that causing the flow into the ventilator, and that is sensed by the machine and giving a breath. That is a whole big route. Instead of that, if we pick up the signal from the medulla oblongata and sensing it and giving a breath, that is called neural trigger. Unfortunately, that is still not available. That is sensing the medulla. But what is available is sensing the diaphragmatic activity and giving the flow. That is called NAVA. So NAVA trigger is already there, but the medulla trigger is still in the process. Maybe we will get to see in next 10, 15 years.
So what is it now?
NAVA is a neurally adjusted ventilatory systems. We'll come to that later.
Okay.
So this pressure and flow triggering is already when the diaphragm contracts, intercostal muscle contracts, and there is a negative pleural pressure created and the flow is generated in the circuit. Whereas neural trigger is before that thing happens. That means the electrical signal is picked up either from medulla oblongata or from the phrenic nerve or from the diaphragm. But what we have right now is from the phrenic nerve and diaphragm, because we are putting a catheter into the esophagus and we are picking the signals, electrical signal from the diaphragm and the phrenic nerve, and it can trigger. Whereas medulla thing is still not clinically available, but research is going on, right? So the best is actually neural trigger, but unfortunately it is not available easily. And even the ventilators which you do now are very, very expensive, probably 25-30 lakhs. Whereas, and also you need to put a catheter into the esophagus and do it. Whereas pressure triggering and flow triggering are easily available. So understood this concept of triggering?
Yes.
Okay. So pictorially, I want to show you how does it work. So now this is our, this is how we breathe. CNS, medulla, phrenic nerve, diaphragmatic excitation, diaphragmatic contraction, chest wall and lung expansion, airway flow, pressure and volume changes. So the flow and pressure triggered are right here. But what we are trying to achieve is getting signal from CNS and triggering the ventilator. We haven't achieved it yet, but what we have achieved is diaphragmatic excitation we are picking up and triggering the ventilator. So we are halfway through, right? So this is NAVA. We'll not go into this detail now because this is another mode of ventilation. We'll talk about it later. Now, how does the pressure triggering works? So as we already discussed, and some of you have answered already. So once the patient begins to breathe in the first microseconds, suppose this is the time, this is the pressure, patient is in the exhalation phase, and suddenly patient begins to breathe. That is in the first microseconds, the pressure drops because of negative flow, because he's exhaling and suddenly he starts inhaling, the flow the pressure drops, and this drop in the pressure is triggered, picked up by the machine as a patient effort, and it will oblige the patient with a breath. So this is how it works. Clear?
Yes.
Okay. Now, pressure triggering was the first to come actually. It needs less technology, and the ventilators with pressure triggering were less expensive, whereas flow triggering is little more complicated and little more technology driven. So it is more expensive, but most of the modern ventilators nowadays have both pressure and flow triggering. But before you buy any ventilator, you should always ask them whether they have flow triggering, but most of the modern ventilators do. I'm not saying one is better than the other, but theoretically flow triggering is much better compared to pressure triggering because it is much more faster triggering mechanism. So how does the flow triggering works? Now, for flow triggering to be understood, you see this diagram. For example, this is expiration. Patient is exhaling. Patient is exhaling means the expiratory valve is open. Please follow my cursor. Yeah. So patient is exhaling, is going through this. This is the inspiratory limb. This is the expiratory limb of the circuit. Exhaling, patient is exhaling. And when they have flow triggering, what these ventilators have is something called a bias flow. Bias flow is not the main flow, which comes after the patient triggers the breath. That is the main flow of breath. But throughout the cycle, expiration and exhalation and inhalation, there is a constant flow across the inspiratory limb. Like for example, here 0.5 liter is going in and 0.5 liter is coming out, right? Because the patient is exhaling, this 0.5 liter goes through this and goes out. So it is constantly being monitored here. Now, let us say patient begins to breathe, right? Patient begins to breathe. Early inspiration. When I say early inspiration, first micro or nanoseconds of inspiration. Patients take a little breath. So what happens to this bias flow? Instead of 0.5 liter going back into the circuit, this closed circuit, little bit goes here, right? So this drop in the flow, this drop 0.5 to 0.4, because some of it is drawn into the patient, this is sensed by the machine. And once it senses, what does the machine do? It closes the exhalation valve. It closes the exhalation valve. Once the exhalation valve closes, machine gives a big breath, whatever you have set. So this is how the flow triggering works. So obviously you can see this is much more complicated, more technology is needed. So that is why it is a little more expensive, but most of the modern ventilators incorporate that. Am I clear about the flow triggering?
So where will be the sensors of this? In the proximal.
Okay, this is inside the machine.
Inside the machine.
This circuit is inside the machine, in the inspiratory limb. So this is constantly, it is flowing like this. Sorry. This is constantly flowing like this in a closed circuit. Once there is a little bit draw from there, it senses this draw.
Okay.
And once the exhalation valve closes, the major flow, whatever 40, 50 liters, and whatever pressure you have set or volume you have set goes into the patient. So this is the bias flow, not the main flow.
Okay. Okay. Okay.
Is it clear?
Yes.
Okay. So this is much more sensitive. The concept is the same. See, when the patient takes a breath, first microseconds, there is a pressure drop and there is a flow. In the pressure triggering, you are sensing the drop in pressure. In flow triggering, you are sensing the drop in flow.
Yeah.
Okay. Yeah.
Yes.
Okay. And now we are not going to talk about in detail now, but now you have the concept that, you know, when there is a diaphragmatic activity, before even this flow happens, it is sensed and the machine gives a breath, right? Okay. So the second question, what is the limit for inspiration? This is easier. What is the limit for inspiration? Usually limit variables can be
Time.
not time, either the pressure or the volume, right?
Yeah,
You will say,
volume,
I want to reach this pressure or this volume. That's it. Your limit set usually is, I want PIP of 20 or tidal volume of 200, something like that, right? So either it is volume or the pressure. Correct?
Yeah.
Now,
So
as I told you,
desired volume.
Sorry?
So the limit variable would be, so the
Either pressure or volume.
Yeah, the desired tidal volume.
Either you set a pressure limit or a volume limit.
Yeah.
Now, as I told you, I mean, don't get hung up on, you know, whether pressure limit ventilation is better, volume limit ventilation is better, because as you know, in physics, there is no pressure without volume, there is no volume without pressure. It is just that what you want to control as a primary variable. That's what the discussion is about. There is nothing like pressure ventilation or volume ventilation in isolation. Whenever you do pressure ventilation, volume moves. Whenever you do volume ventilation, pressure changes. It is all, as I said, that's why it is always think ventilation as a flow rather than pressure and volume. Pressure and volumes are the variables you set as a primary variable. The other one changes accordingly.
Yeah.
And what is the relation between pressure and volume? Sorry?
Inversely proportional.
Compliance, right? Compliance is volume change by pressure change. Correct. If given for the given compliance, if pressure increases, volume increases, pressure increases for the same compliance. So, correct? If compliance goes down for the same pressure, volume will be less. And if the compliance increases for the same pressure, volume will be increased. So pressure and volume are interdependent based on the compliance. Correct?
Yes.
Yeah. So this is the second one. Third one is the cycle variable. That means, how do you, for example, see, it is always when a patient is on the ventilator, best scenario is patient determines every phase of ventilation. He should determine when to breathe in, when to breathe out, and how much pressure he gets. That is the ideal. That's what all these modern ventilators with newer modes of ventilation are trying to achieve. To be most patient friendly and most in sync with the patient. That is why the complexity is, right? So now, in the cycle variable, that means when does the inspiration end and when does or in other words, when does the exhalation starts? Who can decide this? Again, if the patient is on the ventilator, either it is a machine or the patient, correct? Now, how does the machine knows when to cycle from inspiration to expiration? That means how does clinician tell the machine, okay, this is the time you should exhale? That means you should open up the exhalation valve. How do we tell the machine?
Set the time. Huh?
Exactly. So time cycle, right?
Yeah.
Now, in the olden day ventilators, particularly the anesthesia ventilators in the operating theater, used to have something called as time cycle. Is the most common in most ventilators. In olden ventilators, there used to be certain pressure is reached, and then suddenly exhalation used to start. We don't use that anymore. And also volume cycle. For example, 30 years ago, we used to use that. Like you give 200 cc of tidal volume. Once 200 cc is reached, exhalation valve opens and patient can exhale. But now most of the modern ventilators have time cycle. That means when you say rate of 20 and I time of 1 second, that means after 2 seconds of exhalation, after 1 second of inspiration, and every 3 seconds, the exhalation valve opens to let the patient exhale. So it is time cycle. So the only way machine knows how to cycle is by time you set. Right? Is it clear?
Yes.
Pressure cycling and volume cycling we don't do anymore. And don't get confused with pressure limiting and volume limiting. That we still do. But that is the limit. In the sense, we set the limit for this much pressure. But that pressure may be held for 1 second or 1.5 seconds also. Cycling, we are talking about. Cycling is mainly by time cycle. Now, as I told you, the best is for the patient to determine when to cycle, right? So how can the patient tell the machine, okay, I want to exhale, please exhale? How can the patient tell the machine?
Flow.
Sorry?
Change in
Positive pressure.
So how does it do it? How does the machine know, okay, patient is ready for exhalation, I should open up the exhalation valve? How does the patient tell the machine?
Change in flow.
Generating positive pressure.
So that means he already started exhaling and then it will open up. That's what you're saying.
Maybe microseconds.
No, yeah, but the thing is, if he starts exhaling with the exhalation valve closed, there will be a lot of discomfort, right?
Increasing the flow, inspiratory flow.
So you have to do it before he actually starts exhaling.
Critical flow rate.
Yeah, Vikram, your thinking is right, but it will be too late if he starts exhaling, like inspiration. If he starts exhaling and then the valve opens, that for some microseconds he will be exhaling with that valve closed.
Correct.
That is not good.
Then time.
Minimal critical flow rate.
Time cycling is what we clinician tell the machine to do. Now I am asking, how can patient tell the machine, I am ready for exhalation, please open the exhalation valve?
Medulla oblongata.
No, that is not available yet. Yes, that's not available yet.
Critical flow, sir. Critical flow.
Huh?
Critical flow.
Sir?
Minimal critical flow rate.
So that is called flow cycling. Let me explain the concept, then you'll understand. That is called flow cycling. Again, flow cycling is a technology driven, too much technology needed. So not all ventilators have flow cycling. So when somebody tries to sell you the ventilator, you have to make sure that the flow cycling is available. Otherwise, it will only be time cycle. Flow cycling is technology, a lot of ventilators do not have flow cycling. So you have to make sure the flow cycling is there. So this is how it works. Now, this is how the flow cycling works. So x-axis is time and this is flow, right? It doesn't matter whether it is volume ventilation or pressure ventilation. Now there is a peak flow. Inspiration, you follow my cursor, right? So the flow is reached, the peak flow is reached. And you have reached certain pressure limit you have set or volume limit you have given. For example, you have given 200 cc of tidal volume or a peak pressure of 20, that is reached. Once that is reached, what happens? Slowly the flow decreases, right? And also remember at this stage, also patient is also breathing on his own. This flow cycling is only important if the patient is breathing on his own. If the patient is not breathing on his own, it is only time cycle. Because if he's paralyzed, all of these don't work. This is only patient who is spontaneously breathing. So what happens? The flow keeps, once it reaches the peak, it slowly comes down. As the patient's effort is decreasing, that means his inspiration effort is decreasing, the flow keeps coming down. And you can tell the machine, once this peak flow reaches to 20% of peak or 10% of peak, that means there is the end of inspiration effort, and please open the exhalation valve. And then the exhalation valve is open. This is what is flow cycling. This is how the flow cycling works. Is it clear?
Yes, so again, the sensors are inside the machine.
Yes. Sensors are inside the machine. The peak flow is reached. Patient gets what is set, for example, 20 of pressure or 200 cc of tidal volume. And the patient's inspiratory efforts are decreasing. So the flow keeps decreasing because the machine has already given the flow. Patient's effort is decreasing. So the flow is decreasing slowly because patient is not making any effort. And once the flow reaches 20%, or you can set this 20% or 10%. Normally we set it at 10% or 20%. We don't change it much. And once the 10% is reached, the algorithm is open up the exhalation valve so the patient can exhale. Yeah.
So almost all the flow cycling ventilators, they are set at around 10 to 20%.
10 to 20%. You should not change that. Yes, correct. Because if you make it 40%, imagine if you make it 40%.
No, I completely
it will be,
understood.
yeah.
So these things we don't change. It's already by default, we continue.
Right, sir.
Yeah, okay. So we'll move on. Huh? So now we understood the three important phases of ventilation, right? Beginning of inspiration, peak of inspiration, and cycling, beginning of exhalation. So depending on that, if you answer the questions, those three questions, you will get all types of breaths and all types of modes of ventilation. So let us go one by one. Now, controlled breaths, right? When we say control, see, when we say controlled breath, who triggers the breath?
Patient or machine?
No, machine. Controlled breath means machine. So how does the machine trigger the breath? It is time triggered, correct? Yeah. And limited by the machine in the sense is either it can be pressure controlled or volume controlled. Correct? And cycled by the ventilator. So in other words, controlled breaths are time triggered, either pressure or volume limited, and time cycled. Correct?
Yes.
Okay. So we'll go one step further. Assisted breaths. Who triggers the breath? Patient is triggering. It can be pressure triggering, it can be flow triggering, or it can be NAVA triggering. Any of those. Right? If you have a NAVA ventilator, it can be triggered by NAVA. But it is the patient's effort which is triggering the breath. Not time triggered. So it is triggered by the patient. Again, limit can be, it can be volume assist or pressure assist. You can say once the patient triggers, give 20 centimeter of water, or you can say 200 cc of tidal volume. It is the same, pressure or volume limited. And cycled by ventilator. So what type of cycling is that?
Flow.
Time cycling, time cycling, time cycle. It is cycled by the ventilator, not by the patient.
Assisted, okay.
Yeah, this is assisted. Next one will be supported breath. Your classic pressure support. Who triggers the breath?
Patient.
Either pressure triggering, flow triggering, or NAVA trigger. Limited by the ventilator if it is pressure support, or you can say volume. We will come to that later. And cycled by the patient. So it has to be flow cycling. So the difference between, so in controlled breath, everything is done by the machine. In assisted breath, one thing is done by the patient, other two are done by the machine. Supported breath, only one thing is done by the machine, which is giving certain amount of pressure, but both triggering and cycling is done by the patient, right? And if you go one step further, that's what we are all doing right now. We trigger, we limit, we cycle our breaths by ourselves. Our brain controls when we want to breathe, how much we want to breathe, and how much when we want to exhale, right? So that is spontaneous breathing. So in any mode of ventilation, any patient, there can be only 4 types of breaths. So always think like that, like what type of breath is patient getting in this mode of ventilation? Then you can answer all the questions. So this is very, very important. As I said, 3 question approach to ventilation and these 4 types of breaths. If you understand this, you will understand any ventilator mode, whatever the company wants to call the mode. If you go into their manual and look through, you will realize that this is how it works based on this philosophy. Yeah. So any question about this?
That's very clear, sir. Any doubts to the postgraduate students? I mean, very well, succinctly and clearly explained, sir. I don't think, and I have no doubts. Postgraduate students, at least the 2nd and 3rd year, they don't have any doubts.
See, I think you know what they should do, Vikram. They should go back to the ventilator and look at all these knobs. What all each knob indicates, how you can change all these different. Anyway, next few slides will be the modes of ventilation. So when we go through that, it will be very clear. Yeah.
Sir, we have 20 minutes left.
20 minutes left. Okay. I think, yeah, we will quickly go through because we have to go through the modes, and this will be mainly questions because we have understood all the concepts. Now all the modes will be based on this. So
yes, sir.
We'll finish as much as possible, and the other complex modes we can do it later. No problem. Okay. Okay, I'll go next.
Yes, sir.
Okay. Now, if you look at anything you want to learn, you have to go back to the history. You go back to the history and learn how actually it happened, right? So if you go back 60, 70 years ago, maybe during polio epidemic, everything was only controlled mechanical ventilation. That means you put the endotracheal tube, you connect it to the machine determined when to breathe out. Patient had no say, in the sense it was because the computers were not there. How can you sense patient is breathing unless you have a rapidly responsive computers, right? That has to be there. So it was not there 70 years ago. So obviously you put on a ventilator, it is just like putting on the ventilator and bagging, manual bagging. Patient has no say. You are determining when to push the bag in. That's how we started with our controlled mechanical ventilation. But as the technology improved, we went to assist control. That means the technology was available to sense that the patient is making an effort. That was the first step. Then what happened? It became assist control. That means patient, when he's breathing, the machine gave a breath, but also every 3 seconds it gave a breath. So that was assist/control. Then intermittent mandatory ventilation. So the problem with assist control was every time patient made an effort, it gave a breath. That means if the patient is breathing 60 per minute, it gives 60 breaths, which were with a lot of pressure. So that means there was a chance for hyperventilation because the technology was not there to allow the patient circuitry so that the patient can breathe normally in between the mandatory breaths. So that came later as intermittent mandatory ventilation. But still, this was not good enough because you may be breathing, you may be exhaling, and the machine may be inhaling, or you may be inhaling and the machine may be exhaling. There was no synchronization of the breaths. So with modern technology, again, with computers, we reached what we call as now SIMV. So this is how the history of the ventilation, progressed with more and more responsive, computers, more and more feedback loops. So this is how it progressed. Because there are only 20 minutes, I'll skip through this and then we'll go to the. Any question about this? All right.
No, sir.
So obviously you can see in CMV and assist control, there was no way you can wean. Either you are on the ventilator or you are not on the ventilator. You get better, you extubate. Because you cannot wean the rate in these two modes, where suppose you are breathing at 40 per minute, you get all the 40 breaths assisted. Or you set a rate of 30 on a ventilator, you get 30 CMV breaths. So these were not weaning modes. The first weaning mode was IMV, and of course SIMV was the further refining of weaning modes. Now let us quickly go through the modes of ventilation. Okay, whenever you talk about ventilation, you should always know the graphics. Quickly, this is flow versus time. Time is always on the x-axis. Time versus flow, time versus pressure, and time versus volume, right? So remember this, and then we'll go through the ventilator. So this is how we spontaneously breathe. There is positive flow during inspiration, negative flow during exhalation. This is how we breathe. Pressure, negative pressure during inspiration, and then positive pressure during exhalation, right? As opposed to what we do in the mechanical ventilation. And of course, volume is reached at the peak, and then volume comes down, volume goes up. So this is the loops. This is, sorry, not loops. This is the scalars. Flow, pressure, and volume scalars. Now, so let us start with the simple modes, because we are talking about the modes for next 15-20 minutes. Now, what is CPAP? Continuous positive airway pressure. That means there is a continuous pressure during the entire cycle of breathing. So all you do in this mode is so all you do in this mode is a continuous pressure, one level of pressure. That's all you are doing, right? Nothing else. So this is what you do with your nasal CPAP in newborn or in your NIV CPAP. Basically, you get a positive pressure. So tell me now, what are the types of breaths which are there in this mode? We talked about 4 types of breaths: controlled, assist, spontaneous, and controlled, assist, supported, and spontaneous. What are the types of breaths which are there in this? Quickly. All spontaneous. There are no controlled breaths. There are no assisted breaths. There are no supported breaths. Correct? So obviously, you can only put somebody on CPAP if they are spontaneously breathing, right? So that is very obvious. So all you are doing is giving a background pressure of CPAP level, which is also, positive end expiratory pressure, PEEP, right? Okay. Now, Now, this is your controlled mode of ventilation, pressure controlled mode, right? Now, controlled mode of ventilation, you can see here. What are the types of breaths which are there in the controlled mode? Out of all the 4 breaths: control, assist, supported, spontaneous.
Control.
Only control, right? Because all the ventilator is doing is for example, let us say every 3 seconds. We have set a rate of 20. Every 3 seconds, that is time cycle, machine is giving a set pressure level, and I time and E time you set, and after certain E time, after certain I time, the expiration starts, and then the inspiration starts. So this is like time triggered, pressure limited, time cycled ventilation. There are only controlled breaths in this, right? But remember, this is historically the control mode. In modern ventilators, if you put on SIMV mode and paralyze the patient, he will still get breaths. You can put somebody on SIMV mode. If you paralyze them, they will still get controlled breaths, right? That is the backup. In the sense, they will get a breath. So though you may not call it as controlled breath, you may still show SIMV, but if you have paralyzed him and he's not breathing on his own, he will still get controlled breaths. Okay? Am I clear?
Yes.
Okay. So what are the types of breaths in this? Only controlled breaths, correct?
Yes.
Yeah. Okay. Now we'll go next one. So this is time cycle, time triggered, and pressure controlled. So this also can be volume controlled also, right? Instead of setting the pressure, if I set the volume, then it becomes volume controlled ventilation. Okay. Now next one. This is assisted mode. Now who triggers the breath in assisted mode?
Patient.
Who triggers? Patient is triggering. So this is the patient trigger. This is pressure triggering by the patient. And once the patient triggers, the machine gives certain pressure level, what you have set, that is pressure control level. And then cycling is done by the machine. So this is patient triggered, pressure limited, time cycle ventilation. So these are assist. What are the types of breaths in this?
Assist.
Only assist breaths, because patient is triggering, but rest of the things are done by the machine. Right. Now, next one. Intermittent mandatory ventilation, right? So now what is IMV? It is a mandatory ventilation, but intermittently patient can breathe on his own. So for example, again, you don't see just the IMV mode in the modern ventilators. If you have used the bird ventilator, olden bird ventilator, you will see IMV mode, where suppose you set a rate of 20. Every 3 seconds, machine will give these breaths. These breaths. Which are these breaths? What type of breaths are these? Controlled breaths. But in between, the patient can breathe on his own spontaneously, right? So these are spontaneous breaths on his own, these breaths. Whereas these are, for example, if I set rate of 20, every 3 seconds, patient will get these machine breaths, but in between he can breathe on his own. What is the difference between this and SIMV?
This is not synchronous.
Correct. It is not synchronized. In SIMV, what happens? Okay, this is SIMV. In SIMV, what happens? If you say rate of 20, every 3 seconds, what the machine does is, computer will divide the time frame into 3 seconds. Whichever the nearest one, if the patient is making an effort, it will try to give the machine breaths based on that. So for example, here, patient is triggering, and then this is volume limited. So machine will give, once the patient triggers, machine will give this much tidal volume. And then after a certain set tidal time cycle, because in SIMV you always set the time cycle, the machine will let the patient exhale, right? But in between, the patient can breathe on his own. The difference between this and IMV was, here is the machine tries to synchronize the machine breaths to the patient's effort. So now tell me, what are the types of breaths in this mode, SIMV? This is what type of breath is this? Assisted breath, right?
Yes.
So these are assisted breaths, and this is spontaneous breath. So in SIMV, you have assisted breaths and spontaneous breath. Now in modern ventilators, you may not see CMV, but for example, this patient, you put on SIMV and you paralyze him. So basically you are taking out the spontaneous breaths. And then what happens? patient is not triggering, so then it becomes time triggered, volume limited time cycle. That becomes a controlled breath, correct?
Correct.
So that's why don't get confused with the terminology. You can put a patient who is paralyzed on SIMV on modern ventilators and he will still get controlled breath. So it becomes CMV automatically.
Yeah.
So you don't have to search for a CMV mode. Right?
Yes, sir. Only
It is not, but it is not the other way around. You cannot put him on CMV and when he starts spontaneously breathing, there will be a lot of asynchrony.
Correct.
So it's better to put him on SIMV. Yeah.
This source put in paralyzed patients, sir. Not in sedated.
Correct. If you paralyze the patient, this becomes CMV.
Yes. If the patient is sedated.
Yeah, sedated also. If he's not heavily sedated, he can still trigger the breath though.
But it won't be a CMV. It will be still a SIMV.
It will be SIMV. Yes, correct.
If
Yeah.
you are paralyzing, you have to fix the rate and as well as the.
No, you already set the. See, when you set SIMV, you are setting the rate, you are setting the I time. So automatically it becomes CMV.
Yes.
Yeah.
Yes, sir.
Okay.
Right.
Okay. So this is volume limited, but instead of setting the volume, if you set the pressure, it becomes pressure limited, right? Okay.
Right.
So these are spontaneous breaths and these are assisted breaths. So there are assisted breaths here and spontaneous breaths. So this is the same SIMV, but instead of setting the volume, you are setting the pressure. Yeah. Okay. Now you also have something called SIMV with pressure support, right? So see here, these are spontaneous breaths, but you are not doing anything for that. Patient is breathing on his own. But instead of leaving this alone, if you say those breaths, I want to give certain pressure support, you can do that by adding the pressure support. Now tell me in this mode, what are the types of breaths which are there? What is this breath? My cursor.
Assisted.
This is assisted breath. What is this breath?
Support.
Supported breath. Correct. Because here patient is triggering. The support is pressure support. And the cycling is done by the patient. Whereas this cycling is done by the machine. So this is assisted breath and this is supported breath. Yeah.
Yes, sir.
Okay. So this is assisted breaths and these are supported breaths. Whereas here, without pressure support, this is assisted breaths and these are spontaneous breaths.
Yes.
Got it clear?
Yes.
Yeah. Okay. So, yeah. Now, this is SIMV volume limited. Instead of pressure limited, I have volume limited. And you can also add pressure support. So these are assisted breaths with volume limitation. And these are supported breaths. Got it?
Yes.
Okay. Now, pure pressure support ventilation, right? Now, this is, you have to see who is triggering the breath here.
Patient.
See, all these breaths are triggered by the patient. Once the patient triggers, machine gives certain pressure support, say 10, 15, 20, whatever. And cycling is done by the
Patient himself.
patient. So this is pressure triggered, pressure supported, patient cycled ventilation, pressure support ventilation. So what are the types of breaths in this?
Supported.
Only supported breaths. For example, you put them on pressure support ventilation, obviously they have to be breathing on their own, right?
Right.
Yeah. You cannot put somebody who is paralyzed on this mode of ventilation. But of course, in modern ventilators, there is a safety backup. If your pressure support ventilation, if you paralyze them, you may have to they go up for backup ventilation of pressure control ventilation. So some ventilators, if you see, pressure support / pressure control, it says. That means as long as they are breathing on their own, it will be pressure support. If you paralyze them or they stop breathing, it becomes pressure control ventilation. For that, you have to set the I time and rate and all these things. But pure pressure support ventilation, all you have to set is the pressure support level, nothing else.
Yes, sir.
Yeah. So this is the set pressure support level. Okay. Okay. Now the problem with pressure support ventilation is, suppose you set the pressure support and for some reason the lung compliance goes down. For example, he develops pulmonary edema or he develops a lot of secretions, compliance goes down. Then what happens to the tidal volume?
It goes down.
Decreases. Yeah. So once the compliance goes down, what happens to the tidal volume? It goes down. So unless you increase the pressure, tidal volume will not come up. So in this case, you have to manually increase the pressure support. Then only the tidal volume normalizes. Right?
Yeah.
Why am I saying that? Because there is one more ventilation. I will go to this. We have time. Okay, we were overshot. But it won't stop, right? Or it will stop in 2 hours.
No, sir.
6.
Huh?
Is there for
Another 15 minutes, sir.
Oh, okay, fine. Then we'll, you have, okay. So this is pressure support ventilation. In the sense here, the compliance goes down, the tidal volume goes down, and you have to clinically, I mean, as a clinician, you have to increase the pressure support to readjust the tidal volume, correct?
Yeah.
Yeah. So why am I saying this is different from volume support ventilation. We will talk about it a little later. So this is pressure support ventilation. Now, there is also called CPAP with pressure support. So basically here you are setting CPAP level and the pressure support level. What are the types of breaths in this mode?
Support. Spontaneous. With some support.
No, all of them supported. So it is a supported breaths only. There is no pure spontaneous breath because every time patient makes an effort, he gets a pressure support, right?
Yeah.
Yeah. So the only supported breaths are there in this. Now, this is very interesting because we always think that volume support is volume support. It's actually pressure support. How does it work? Now, in volume support ventilation, or as I said, some of the ventilators call it as volume guarantee or mandatory minute ventilation, all those things. What do you set in volume support ventilation? What are the parameters you set? Tidal volume, correct?
Yeah.
Right. So you set the tidal volume, follow the cursor, you set the tidal volume. So what does the machine do? Machine tries to give 2-3 test breaths and it determines how much pressure is needed to achieve that tidal volume. Right? It will easily do that. It will give you 5 centimeters, 8 centimeters, 10 centimeters and sees how much tidal volume is generated. And if whatever you have set, if it is reached, it will keep giving that tidal volume. Right? Now, let us say in this mode, you set the tidal volume. Machine determines the pressure support by giving test breaths. And it determines, okay, this much pressure is needed to achieve this tidal volume. Now, if the compliance goes down, secretions, pulmonary edema, pleural effusion, whatever, then compliance goes down. What happens to the tidal volume?
Decreases.
It comes down. But you have told the machine, I want this much tidal volume for sure. So what does the machine do now? When it sees that the tidal volume is diminished, it will increase the pressure support automatically to achieve that tidal volume back. In that way, this is different than pure pressure support ventilation. Volume support also uses the pressure support. But what is the big difference between pressure support and volume support ventilation?
Pressure is determined by the machine.
This is closed loop. This is a feedback loop, whereas pressure support is not a closed loop. It is an open loop. In the sense, if there is a compliance change, you as a clinician need to increase the pressure support. Correct? Whereas here, the machine does it by itself. It is sort of a self-weaning mode.
Yeah.
It will keep changing the pressure support depending on the patient's compliance. So that is a big difference between volume support and pressure support. But both of them actually give pressure support only. Whereas volume support, it assures certain tidal volume. That's why it is also called as volume guarantee ventilation in certain ventilators. It is the same as volume support ventilation. Yeah?
Yeah, makes sense. Otherwise, flow will not happen at all.
Sorry?
It makes sense. Otherwise, there won't be any
Yeah.
flow of.
Yeah. Okay. So now, so this will restore the tidal volume and it becomes a closed loop ventilation. Like in the sense, it will keep changing the pressure support to achieve the target tidal volume.
Yes, sir.
So this is also called volume target or volume guarantee or mandatory minute ventilation. In the sense, certain ventilators, it is called mandatory minute ventilation. Example, you tell the machine, I want 100 cc of tidal volume and rate of 30. That means I want a minute ventilation of 3 liters. 200 tidal volume and 300 tidal volume and respiratory rate of 10. That means 3 liters. I want mandatory minute ventilation. Then it will adjust the pressure based on that, right?
Right.
So this is volume support ventilation in a nutshell. Set tidal volume. Machine checks the compliance by 3 test breaths. It determines the pressure support level needed to achieve this. And then it keeps delivering this tidal volume. And compliance changes, then it increases the pressure support level needed to achieve that tidal volume. So it is a closed loop ventilation. So pressure regulated volume, I will stop just after this because this is somewhat related mode. It is similar to volume support. This is how it works. You set the tidal volume, rate, and I time, right? That's what you set on a pressure regulated volume control. So machine again gives 5 test breaths, increasing pressures to see where exact or what exact pressure is needed to achieve the tidal volume. And then it delivers the pressure controlled breaths with set I time. That is the difference. Though it is called volume control, in fact, the flow will be like pressure, decelerating flow, because it gives certain pressure to achieve the tidal volume. Why is it better than regular volume control? Because in volume control, it is as I told you, in volume control, it is always constant flow. Whereas here, it is a decelerating flow, which is considered to be better for air distribution in diseases like ARDS, which is diffuse areas of lungs with different compliance. So then it is better for air distribution uniformly. The decelerating flow is better. So basically here, volume control ventilation is given, but it is through pressure regulation. So that's why this is better than regular volume control ventilation. This is one of the common modes I use personally because this achieves both pressure regulation as well as volume control. Readjust the minimum pressure. So the algorithm is similar to volume support, but only thing is volume support you use in a patient who is spontaneously breathing, whereas pressure regulated volume control is something you use in a patient who is not spontaneously breathing, or you are just intubated, then you can use it. In fact, Mackay ventilators have something called volume support / PRVC. That means as long as the patient is not breathing spontaneously, it will be PRVC. The moment the patient breathes on his own, it will switch to volume support. It's called dual mode. Make sense?
Right, sir.
Okay. I think I'll stop here because you may have questions and I don't want to overload with you because there are a few others, but we can include that in the advanced ventilation because I had some of these. I'll show you. See, this is volume adjusted pressure support. All these are related sort of modes. Adaptive support ventilation, APRV, BiPAP, proportional assist. All these I had in mind, but I think we will stop it for now. And if you have any questions, I can. So basically, see, remember, regardless of which mode is used, your aim of ventilation is to keep the patient alive till the natural process or what you intervene makes him better. It is to avoid lung injury rather than fixing anything. I mean, ventilator doesn't fix anything. So basically, it is a life support. And keep the patient comfortable and keep the patient from dying. That's what the ventilator does. No ventilator has saved any lives in the sense, not directly. Of course, it has saved lives, but not directly. And so that's what it is. So I think if you understand these basics, tomorrow when you go back to the ventilator, to the patient bedside, play with the ventilator, see all of this makes sense. Yeah. Okay.
So thank you so
Yeah,
much.
that's all. Yeah.
We have recorded the